Aiboan and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, bringing to you your weekly dose of wellness here on Healthline. And today, as our topic of discussion, I thought of talking about a common condition that we as doctors face in the healthcare sector, and that is none other than urinary stones. And to discuss this topic, we have a giant in the field of urological surgery joining us today to share his expert opinions. He is a senior consultant urological surgeon at the National Hospital of Sri Lanka and also a professor of urological surgery at the Postgraduate Institute of Medicine. He is none other than Professor Neville Perera. A very good evening to you, sir.
Good evening, Dilshan.
And now getting down to the topic at hand, urinary stones. When we say urinary stones, it basically means stones in our urinary system. So, what are the commonest sites where these stones form in the urinary system?
Yeah, actually speaking, most of the stones are formed in the kidneys. Actually, the kidneys are the organs which filter urine, and then all these constituents of stones like calcium oxalate, they all go through the kidneys, and the starting point of any stone is the kidneys. And some stones will roll down to the bladder, that is lower down, where you collect your urine and then grow into a large stone. But the point where it all originate is the kidney.
And when we analyze the history and we analyze the current situation, we have seen that bladder stones were more common in the past, especially in the children. But the situation seems to have changed now. Why is that?
Yes, this was a common finding in European countries, especially in England, few decades ago, because of the malnutrition. What happened was the bladder, the surface lining of the bladder was weak, and that was making a center point for stone formation. And a lot of malnourished children had bladder stones. But then malnutrition is unheard there now, and even in developing countries and developed countries, that degree of malnutrition is no longer seen. So the bladder stone, the prevalence came down, and now what you see in most occasions are even in children and even in little children, the kidney stones.
Right. When you talk about prevalence and urinary stones, how prevalent is it in Asia as opposed to other continents? And when we consider Sri Lanka in your day-to-day practice, how often do you see these urinary stones?
Yeah, the exact prevalence is not very well known in Asian countries, but it's certainly less than when you are compared to the Western countries. Because the exact reason we are not quite sure, because it may be that all the stones are not revealed in or not taken into account in our part of the world, unlike the West. But it is about, say, we see about 7,000 cases a year. So that is the rough figure I can give you, because our unit itself treats about, say, 3,000 to 4,000 cases, which is the largest center, and then other centers are also now there. So putting everything together, that is the figure I can give you.
Right. And now Sri Lanka is a country with a hot and tropical climate. In your professional opinion, do you think that these climatic conditions also somehow predispose towards formation of urinary stones?
Certainly yes, because dry weather and in hot and temperate climates, you sweat more. And what happens is your body get dehydrated and then your urine get concentrated. So in concentrated urine, these little crystals, little particles which form stones get precipitated and you form more stones. So in hot climatic conditions, stone formation is more prevalent. So that's why we see little more stones in our dry zone.
Right. Talking about dehydration, we have seen that fluid intake plays a major role in either precipitating or relieving stone formation. What is your opinion about fluid intake? Is it that the more fluid we take, the less chances of fluid formation, stone formation? Is that so?
Yes, actually speaking, getting well hydrated, I think generally an adult is advised to take roughly about 2 to 2.5 liters a day keeping enough space for sweating and passing the amount of urine you are passing. So you are supposed to take about 2.5 liters a day, and then anything less than that, going towards less than that, will make your urine more concentrated, as I was mentioning earlier. So fluid intake is one of the most important things which are needed to prevent stones. But on the other hand, I must mention that over drinking, say suppose you take 4 or 5 liters a day, that will will make your life really miserable, because you have to pass urine several times. And on the other hand, it can be dangerous because that can increase the chance of making a stone.
And sir, in our day-to-day practice, we have seen that males seem to be more prone to developing stones rather than females. Is it something to do with the male anatomy of the urinary system, or is it the male hormones? What is your opinion on that? Why are males more prone to developing urinary stones?
Actually, they have done some studies to find out why the males are getting more stones. It is found in all the countries, universal feature. And what they think is that their food pattern has some effect on this, because they take more proteins in some societies. They take more proteins, and it is well known that high protein diet causes acidic urine, in which the stones can get precipitated more. And then again, in our part of the world, if you take people, the men work in an environment where you are subject to higher degree of dehydration. So that may be the reason why the males get more stones.
Right. You spoke of acidic urine, and we know that for stone formation, the acidity of urine is essential. So talking about, you spoke about high protein intake as well. So what are the other foods that might lead to acidification of urine and in turn lead towards stone formation in urine?
Yes, actually apart from food, I think there are actually the red meat and fleshy food, I think is the main reason to have a high acidic urine. Other than that, certain drugs and taking high doses of vitamin C in some people can lead to a high acidity in urine.
Right. And as we know, sir, now urinary stones is a multifactorial disease. So considering the risk factors, according to you, what are the most common risk factors that predispose towards stone formation?
Yes, if you think of risk factors, I think as we were mentioning, dehydration is the number one. So that is something you have to prevent. And on the other hand, the predisposing causes are, if there is any block or any delay in passage of urine or flow of the urine, say from kidney to the exterior, if there is any block anywhere, that can lead to what we call stagnation of urine, and that can lead to stone formation. On the other hand, if you get recurrent infections, repeated infections, these dead bacteria and cells inside your urinary tract can act as a center point for stone formation, what we call a nidus. So those are main reasons, and also there are genetic and inherited factors.
Right. You talk about genetic and inherited factors, and we see that there is a common belief in our society that urinary stones run in the family. So is there indeed, like you mentioned, what is this genetic predisposition? Are all patients who develop urinary stones, do they get it from their family, or is it only a portion of the patients who are affected by it?
I think all the studies have shown very clearly that it is a minority of people will have this stone formation running in families. So that is fortunate for us. So very few diseases, there are few diseases which are passed from the parents to children, which can predispose to stone formation, like polycystic disease and such diseases. But on the other hand, if you take genetic basis, that means that you are not getting that tendency from your parents, but it is inside your body, it's in your genes to form stones. Those are called genetic diseases. So genetic diseases are getting more and more prevalent, because when you look at the people who make stones in same family, one person will keep on forming stones while the other will not, because that feature is there in your genes. So the genes decides whether you are going to form a stone or not.
We spoke about risk factors for stone formation, and now we have seen that alcohol intake and smoking, they predispose towards most of the diseases. What is the role in smoking and alcohol intake in urinary stone?
Yeah, I think the smoking has been shown to associate with stone formation, because it makes certain changes in your urinary system, urinary tract, and form certain chemicals, so which can predispose to higher formation of stones. But on the other hand, most of the studies, I think there are a number of studies which have studied whether alcohol has a direct relationship, but they have failed to show a very sort of direct relationship between alcohol and stone formation.
And also you spoke of overuse of vitamin C. Are there any other drugs, especially if used unjudiciously, that can lead towards formation of these urinary stones?
A well known drug, I would say, is that there is a anti HIV drug called Indinever. I think if you are compelled to take that if you have the disease. So that sort of a drug, if you take it for a long period, it can form stones.
Right. In the beginning, sir, you were talking about calcium oxalate stones. Is that the only chemical constituent in these stones, or are there different types of stones, and does these different types lead towards different outcomes of the disease?
Yes. The commonest type of stone will be calcium oxalate, and there are two constituent variants called oxalate monohydrate and dihydrate. Monohydrate stones are very hard and very difficult to treat, but about 80% or 90% of stones are calcium oxalate. But other than that, you can get very large stones called calcium magnesium ammonium phosphate or triple phosphate, which forms huge stones which are called staghorns, because they look like staghorns. And also there are rare stones like cysteine stones, and another one is uric acid stone. When you form more uric acid in your body due to various diseases like gout, or sometimes when the leukemias and other blood diseases are treated with chemotherapy, you form a lot of uric acid. So this sort of a situation, you can form these rare stones which are uric acid or cysteine stones.
Now, sir, when a person develops a urinary stone, until it is big enough in size to cause symptoms, it may be there as a silent stone. So, especially in a person with a strong family history of urinary stones, is it really required that such people, do regular screening to see whether they develop urinary stones?
Yeah, that's a good question. Because if you have a strong family history of forming stones repeatedly, then of course you might have inherited the gene from your parents. So in which case, rather than waiting for a stone to grow and become bigger and it is become more difficult to treat, it's better if at least annually, if you can do a simple test like an X-ray or a scan and check whether we are forming more stones.
Now, moving on to the symptom profile of urinary stones, we see that the most commonest symptom is severe loin pain, mostly radiating to the groin. What are the other common symptoms of urinary stones?
Sometimes you get, now if you have a small stone rolling down from the kidney to the bladder, then you will get this severe pain called renal or urinary colic, which is described as a very severe pain. And but if you have a silent stone, sometimes a big stone even in the kidney, you might get only a dull ache in your loin area. You will get a dull ache, and then again when the stone is rolling down, it will spread the surface of the water tube and then cause blood in your urine. So you might pass blood in your urine, and also if the stone is blocking your kidney, that can lead to infection, because urine is not flowing properly. That urine can get infected. So you can get repeated infection. So very rarely, if you have stones on both sides blocking the kidneys, that can lead to even acute kidney failure.
You spoke about these symptoms. A person might have one or any combination of these symptoms. So when a patient presents to you with either one or many of these symptoms, what are the alternative diagnoses that you would consider before confirming a diagnosis of urinary stones?
Yes, I think especially if you take an adult, if he comes with severe pain in the loin, I think first thing we will think of is a stone rolling down, coming down. But on the other hand, that can be something other than a kidney problem, like a muscle pain or a bone pain, or it may be a slip disc, or it may be a compression of a loin nerve. So there are many other things you have to think about. So without doing some basic investigations, we should not be straight away diagnosing a urinary stones. On the other hand, especially if he is passing blood with urine, if he is a person who is over 45, the golden rule is that you have to exclude a cancer in your urinary system, and you should not think about stone first. Until proven otherwise, you have to treat it as a cancer. So I think there are many other things which can mimic these symptoms. So investigating those is very important.
Now, you speak of investigations. Is there a confirmatory investigation or investigations that you as a urological surgeon would depend on to confirm that it is indeed a urinary stone that you are dealing with?
Yes, the basic screening test will be a urine full report, which will show some blood cells if the stone is scratching the surface, and then you will be doing a plain X-ray and an ultrasound scan. But one must know that these things are just screening tests. If you see a stone and if you see the state of the kidney in an ultrasound, then of course it's okay. But that doesn't mean that if you don't see anything, there is no stone. So because of that, the gold standard of investigations now has become the CT scan without injecting the dye, without injecting the dye or the contrast. So it's a very simple procedure. So if anybody coming with loin pain and suspected stone, now the gold standard investigation will be what we call a non-contrast CT scan.
When a person does indeed develop a urinary stone, we know that some stones, especially the smaller ones, have a tendency to pass spontaneously. As a urological surgeon, what are the factors that you would consider when moving forward into an intervention?
Yes, stones less than 6 millimeters, there is about say 70 to 90% chance that it will roll down and you will pass it, provided that you don't have a block or an obstruction or a block in the urinary path. But on the other hand, the bigger the stone, lesser the chance that you will be passing it out. So if you have about 1 centimeter stone, there is absolutely no point waiting for it. So small stones less than 4 millimeters, there are nearly 90% chance that you will pass it. So depending on the size of the stone, we decide whether to wait and see or whether to intervene. And also what is more important is what we find in the ultrasound scan. If ultrasound scan shows that the kidney is blocked and bloated up and it may not be functioning, then we intervene very fast.
Right. And now when we talk about interventions in urinary stones, is it always surgery or are there medical interventions that you as a urological surgeon would use before moving on to a surgical option?
Yes. Earlier, so say a few decades ago, I think it was all surgery. But nowadays, we know that small stones will come out on their own, and then you can help that by giving special drugs which relaxes the water tube and then make it wider so that the stones can come out. So smaller stones, like if the stone is less than 6 millimeters or 5 millimeters, there is a special drug to relax this water tube and allow it to come out. So we try it for about a month or month and a half, provided that the kidney is not blocked. But bigger ones, so larger stones, we have to intervene early, and then especially the progress is not good, then again we intervene. The intervention, if you take, is also not surgery anymore. So surgery or cutting open your tummy is done extremely rarely nowadays for patients who have very large stones. But other stones are all taken out through what we call minimally invasive methods or telescopic methods and various sound wave techniques without cutting you.
Right. So, if a patient indeed is going towards a surgical intervention, what can they expect, especially operatively and post-operatively? And when we talk about post-operatively, how many days of hospital stay can they expect, and when can they get back to normal life?
Yes, if we take, let us take a stone in the water tube, which is coming from the kidney to the bladder. If it is a stone which is not going to come out on its own or with drug therapy, then what we do is telescopic intervention. We have tiny long telescopes with laser fiber inside that. So what we can do is we can put the telescope into the water tube and visualize the stone and then crush the stone into dust, so that patient will pass it. That sort of a procedure is nowadays done as a day case. So you come at 4 o'clock and 6 o'clock the procedure will be done under general anesthesia. You have to be fasting, and then by 10 o'clock in the night or evening, after a few hours, when you are talking and walking, you can go home. So with antibiotics and some painkillers. So those are done as day cases. But the larger stones, which will need more sort of involved procedures, like keyhole surgery through a loin. If it's a large stone in the kidney, you have to put a small keyhole and take it out. That sort of surgery, you have to stay for a day or so. So because it's an inward procedure. On the other hand, we have another technique which sends sound waves and crush the stone from outside. It doesn't involve any kind of anesthesia, and that is also a day case. In and out, no anesthesia, no fasting. So depending on the technique of taking the stone out, it will be generally about, even if it's an invasive procedure, it will be a day or two.
Right. We have seen in our day-to-day practice that intraoperatively we insert a urinary catheter during most of these surgeries, and after surgery also that some patients have to stay with a catheter, and patients find that irritating sometimes. Is it always necessary that we do this just for the benefit of our viewers so that they can have a better idea of what they can expect?
Yes, I think what bothers them after stone surgery is mainly the stent. So we put a tiny plastic tube to the kidney, climbing from the bladder to the kidney. If once we have finished the procedure, if we feel that the water tube is all swollen up and it is not going to drain urine, then temporarily we leave a little tube called stent, which you can't see actually, and it is inside you, and only the X-ray will show you that. But unfortunately, this stent has two coils, one in the kidney and one in the bladder. I am sure the people who have undergone this will know this. These coils, the lower coil, can irritate the bladder and make you to pass urine more frequently. Sometimes you get little bit of bladder pain. Sometimes when you walk around you bleed. So that sort of a problem is there. So it is the stent which is giving trouble.
Right.
So but then we put it only if it is essential, and it will be removed within 2 weeks or so under local anesthesia after putting a small telescope into the bladder.
And which will be done as outpatient procedure, I suppose.
Exactly. Outpatient procedure, it takes only about 15 to 20 minutes.
Right. And in a certain number of cases that we have seen, some patients have the tendency for stone recurrence. Is there any particular reason why a person can have recurrence in urinary stones, and is there any particular way that they can prevent it?
Yeah, good question, Dilshan. Because the recurrence is the biggest problem in stone disease, because one thing is that if the stone is completely treated and within 6 months or so, if you get a new stone, we call the patient a recurrent stone former, because he is forming stones. So that cause may be that environmental cause. He may be still getting dehydrated without following our advice, or he may be working in a place where he is subjected to dehydration. On the other hand, if other factors like taking food stuff, which may be precipitating high calcium levels or high oxalate levels, that is one reason why he will get recurrent stones. But on the other hand, if he has a genetic predisposition, say genetic tendency to get stones, or you have inherited the feature of getting stones, then of course you can't prevent it. So those people will keep on getting stones, and we call them recurrent stone formers, and then we keep a very close eye on them, because if they disappear and then come after a few years, they will come with very large stones.
Right. And moving back to interventions, we have seen, especially in the peripheries, patients presenting to us very late in the late stage of stone disease, and if timely intervention is not done, what sort of complications can occur in these patients?
If the patient the stone is left alone, it will keep on growing, because that is a tendency, because these chemicals which form stones, once they find a small stone as a nidus or a center point, this will keep on growing around that. So, it will become a large stone, or else occasionally they will drop into the bladder and grow there. Complications wise, if you think, is the first is that stones blocking the water tube. If a stone gets stuck in the water tube, that kidney will stop working after some time, because it can't drain its urine from the kidney to the bladder. So, the kidney will start getting bloated up, and then at one stage kidney will stop working. So, if this happens in both sides, then the patient will stop producing urine. But if, because we have two kidneys, luckily you won't go into kidney failure if one kidney is functioning well. On the other hand, this blocked kidney is like a blocked drain. So, the moment a drain gets blocked, you know that it will start getting infected, or like a drain, it start getting infected. So, the infection is the other dangerous thing that can destroy the kidney very fast, and that can lead to a dangerous situation called blood poisoning, that is septicemia, or bacteria getting into the blood, and that can even endanger the life. So, those are the main problems with stone blocking the kidney.
And also there is a firmly held belief in our society that if you are a stone former, that you might in the future lead to having a bladder cancer or a kidney cancer. How true is that?
Yes, fortunately it is rare, but then that is it is well known that if you have a large stone in the kidney or the bladder, that can irritate the surface of the kidney and the bladder and make certain changes in the cells. So, those changes can lead to later on lead to a cancer. So, fortunately that is rare, because long before that you generally pick up the stone and treat, but still we see on and off these people coming with large stones and associated cancers.
Right. Now, as a closing statement, Professor, for the benefit of our viewers, what would be your advice on prevention of urinary stones, and what practices that they should practice on a daily basis?
The most important thing I would like to say is that don't ignore the symptoms. What we have to do is that if you get loin pain, if you pass blood in your urine, if you had a dull ache in your loin is the area on the side of your body, and if you get pains, don't ignore them, because sometimes these symptoms come and go. So, if you ignore for the first time, then next time when you are coming, it will be a bigger stone. So, it will be more difficult to treat. So, the second thing is that keep your hydration well, drink enough fluids. So, keep it to about 2 to 2.5 liters, don't over drink. But if you are a recurrent stone former, if you are forming stones, then there are certain food stuff you have to avoid, and then you have to come to a clinician, and then we will give the necessary advice to avoid these food stuff. So, I think that is pretty much to keep you away from stones.
And that, ladies and gentlemen, brings us to the end of this edition of Healthline. We were in conversation with Professor Neville Perera. We thank Professor Neville Perera for taking time off his very busy schedule and gracing our studios here today. And this is me, Dr. Dilshan Fernando, signing off from Healthline. Until I meet you next week with your weekly dose of wellness, Aibowan.